I'll wait for Raymond to tell me when to start. We're good? Okay.
We'll get from the other side, but.
Okay. Let me see who's on. It looks like we got a lot of people on, so we're good probably. Okay, I will start. For those, I was going to say for those who don't know me, but I think now I've met everybody. My name is Evan Richards. I am a secret admirer of Molly Sasha, so it's really nice to see her. But I say that because I've been coming to this hospital for a long time. I've known Ruben forever. And this place means a lot to me. This place means a lot to me. I can't remember if I did the initial training here, if it was Bert, but I've been coming back ever since. And I can tell you that I've been lecturing for probably 32 years now. And not once have I taken for granted the fact that people take the time to listen. So it means a lot to me that you're here. I'm going to try to give you something interesting. Because you have such a great website, or not a great site, but a link to videos of presentations, I was able to go back and watch my own. And I realized I don't want to give the exact same talk I gave back in April or whenever it was. So I've had a lot of new stuff, and I'm pretty excited about this. This will be the first time that I've lectured on many of the things I'm going to talk about today. But I love this stuff, so I'm really happy to share it with you. A little bit about me, for those who don't know me. Let's see if I can get this working. There we go. I did work for Benel for many years. I retired December of 2019, just in time for a pandemic to hit. And but I had some very solitary things that gave me a lot to do during the pandemic, mostly mountain biking with a bike that Benel bought for me when I retired. So I'm pretty excited about that. They kept me as a clinical consultant, but as I did in the last talk, I'm going to dedicate this lecture to my mom. Today's her birthday, October 12th. And if she were still alive, she would be 92 today. And we were going to have a nice dinner for her back in Salt Lake City, but it was important for me to come and spend time with you. So I brought mom with me. This is her horse Flash. She grew up in a small town in Utah. That's her riding bareback on Flash. And she was an incredible mom. She was my doctor, my lawyer sometimes when I got in trouble, my nurse, my mentor, my psychiatrist. She raised me right, and I love her to pieces. And I'd like to dedicate this talk to mom on her birthday. The talk is going to be micropreemies, the new NICU reality. The fact is that we're getting smaller and smaller babies that are showing up at your doorstep if you work in a newborn intensive care unit. To talk about this, Annie Jambet, who I have talked with now on the phone, and I've emailed her many times, is a bioethicist. She's married to Keith Barrington. And then Isabella LeBlanc got involved in this study. I love the name of the study. It was published in 2008. Nobody likes preemies, the relative value of patients' lives. And I thought, this is interesting. And I read it, and I was just blown away by this study. And I talked to Annie recently, and I said, do you think things have changed since 2008? And she goes, no, not really, except for the people who dedicate themselves to babies, which are people like you. But for the most part, people have the same perception of babies that they had when we did this study. Let me tell you a little bit about the study. Why does nobody like preemies? What they did is they sent out a triage survey, basically, to 525 physicians and med students. And they said, how would you triage these patients? And they had three categories. One was the patient had a 50% chance of survival if you intervened with medical care. And if they survive, they would have a 50% chance of being impaired. And under there, they put several patients, a preemie, a term infant, a 2-month-old, and a 50-year-old. The second group were patients that were already disabled before whatever injury it was that befell them. And they had a 50% chance of survival if you did something to try to save their life. Under that group, they had a 7-year-old and an 80-year-old. So both disabled with a 50% chance of survival based on your intervention. The third group were patients that had a 5% chance of surviving and basically 100% chance of impairment if you intervene and step in and resuscitate these patients. And under there, they had a 14-year-old and a 35-year-old. And they said, if all these patients showed up at your doorstep, how would you treat them? Who would you treat? In what order? And this is how they all fell out. The 2-month-old, look where the preemie is, clear down here, just above the 80-year-old who has a 50% chance of survival and is already disabled. That's how much people thought of preemies. Children seem to carry the day, but the smaller the patient got, the less people thought it would be important to intervene. And then they broke it down into gestational age. They said, what if the patient were 28-weeker, a 24-weeker, or a 22-weeker? And in that group, what they found was people tended to think that it might be beneficial to try to resuscitate these patients, or try to intervene or provide medical care. This is kind of a gray zone at 24 weeks, and they said it's pretty futile if you're at 22 weeks. So futility is a vague term, but it's hard to decide what's futile and what's not. But generally, 22-weekers are thought of as futile for intervention, and now they're showing up on your doorstep. This is what people think of them. Well, why did the survey come out this way? Why do people not think that it's important to intervene in a micropreemie? I think the reason why is they really aren't that easy. Number one is these babies are exceptionally fragile. Their lungs are undergoing structural changes. So when I worked with Dick Bland and Kurt Albertine and Brad Yoder in the animal lab in Utah, they kept talking about abnormal structural changes. And finally I said, what do you mean by that? They said, well, you guys call it lung injury. We call it abnormal structural changes. It's normal for a lung to grow and develop, which is what I'm here to talk about mostly, is how does a baby grow and develop? And how do we disrupt those structural changes? Because they said, if you do disrupt those structural changes that are normal, that's lung injury. So you got to be really careful. And I said, well, what causes those disruptions? Is it the ventilator? And they said, usually. These patients are really, really hard to ventilate. If you have to intubate a micropreemie, especially, you have a very high likelihood of disrupting normal growth of the lung. And another problem is babies don't always follow the rules. Guys like me can come in and tell you how to use the jet, and you do everything the way we tell you to do, and the baby doesn't respond. So these babies they're tough, and you picked a very difficult population to work with. Micropreemies, let's say you're working one night and baby one comes in. This was a really interesting photograph that I'm going to zoom in on a little bit. There's my zoom. This was some pictures I found on a website, and if you look down here, I creeped on this guy at the bottom. You might be able to see it. It says ULB Louis Deveau. And so I Googled him, and I kept trying to narrow in on him, and I found him. And he's a professor at a university in Brussels, Belgium. And these are under his pulmonary section. He had photographs of everything. And I wrote to him and I said, these are incredible. Can I use them? What are they, and can I use them? He goes, yeah, these are the lungs, the equivalent of a 22-week gestation baby. And so baby one comes into your door, and he said, these are tough babies. If you look close, you can see that you do have some capillary growth, and you do have some alveolar development, but I wouldn't call them true alveoli. They're probably closer to respiratory bronchioles. So you do have capillaries, you do have some semblance of alveoli, but again, they're not mature at all. At best, they're probably respiratory bronchioles. So you're trying to decide, should we even try to save baby one when baby two comes into your NICU? Oh, whoops, let me go back. Yeah, I did it again. Sorry. Still getting used to my pointer. So baby two comes in, and you can see that 26 weeks, you have a very different picture. This is a baby at 26 weeks. And you can see much improved alveolarization, much improved capillary proliferation. You can see that capillaries are starting to come in contact with the alveoli, but you can also see some alveoli back there are not in really good contact with the capillaries. So you may have a little bit of VQ matching. But one of my favorite terms in neonatology was optimal. I always said you should look for an optimal blood gas, an optimal X-ray. Then I heard a wonderful physician give a talk at a conference, and he said, the worst word you can use in neonatology with micropreemies is optimal. I thought, hey, wait a minute, that's my word. You can't take that up. And he went on to explain that if you try to get an optimal blood gas or an optimal X-ray on baby one, at what cost will it be to the patient? You're not going to get a perfect picture. You're not going to get a perfect number. The word you should be using is acceptable. When you're ventilating a 22-weeker, you look for acceptable blood gases, acceptable X-rays. They're not perfect because they can't be because of the underdevelopment, but they're acceptable. Baby, they're not going to kill the patient. We'd like something better, but that'll come around as the baby starts to grow. Baby 2, I still believe that you should think more optimal than acceptable. You're going to be a little bit more aggressive alveolar recruitment and alveolar stabilization and VQ matching and getting the capillaries talking with the alveoli. But babies are really tough, especially when you get these micropremies. They're not supposed to be born at that stage of development. My clinical mentor, Dr. Tom Harris, I just got to speak 2 weeks ago at his memorial service. He passed away, and before he died, he sent me 3 boxes of stuff on medical ethics. So I'm going through all the baby dose stuff that happened in the United States under the Reagan administration. But Dr. Harris was my clinical mentor, and one of the things he taught me was that I was wrong. I always thought the terminal bronchial connected directly to the respiratory bronchial, which it does. I was right about that. But I thought the respiratory bronchial connected directly to the alveolar sac. That's where I was wrong. And I knew alveoli would start to pop out, and pretty soon the lungs, instead of looking like a bunch of grapes, will look like a sponge. Alveoli will be everywhere. But what he said is you got to remember the alveolar ducts. That's what makes babies so hard. The alveolar duct is more compliant than the alveoli. And he said, I bet 70% or more of PIE occurs because ducts rupture, not because alveoli can rupture, and it's usually the marginal ones that are not surrounded by other alveoli. But more often than not, it's the ducts because they're very compliant. So the hardest thing you're going to do with the ventilator is get the gas to go where you want it to go. And when you do that, you tend to overinflate the ducts, trying to reverse out atelectasis. And that's what causes the rupture, according to my mentor, Tom. This is why there's kind of a double whammy working against the alveolar ducts. The respiratory bronchioles, as you can see in this image, have 2 advantages. One is they have thicker walls, and 2 is they're less compliant. So they can handle the distribution of volume a little bit better, whereas the alveolar ducts have thinner walls and they're more compliant. So they tend to overinflate. So you're trying to get gas to the alveoli, but what you can see right here is you got a couple tears down there in the alveolar duct. I can see at least 2. And that's where the interstitial emphysema is going to come out. And you're going to start to create all kinds of problems for the patient. This was a slide Dr. Anton van Kamp in the Netherlands gave. I was speaking at a conference with him in Edmonton. Twice he came there. And I asked him if I could use this slide. I just loved it. Again, this is what makes babies so hard. Even if the alveolar ducts aren't a problem, the alveoli can still be a problem. He said, let's say you're giving 6 mLs per kilo of tidal volume, but you have no atelectasis. He said the alveoli are probably getting 6 mLs per kilo of tidal volume. But you're happy because you're on 6 mLs per kilo, but if your baby is only 50% recruited, if half the alveoli are deflated, the gas has to go somewhere. So it goes to the areas that are already open and compliant. And he said it's really more like giving a 12 ml per kilo. If you're delivering 6 mLs per kilo to only half the lung, it's probably more like 12. And so the hardest thing you're going to do as a clinician is get the gas to go where you want it to go. And recruiting these babies is absolutely essential. This is what he was talking about, really. This is a subpleural microvideograph from Gary Neiman's lab in Syracuse, New York. And I went to his lab and I saw him set up a rat lung. It was actually a living rat. And they expose the lung and they do these incredible subpleural microvideographs. And what I wondered is, how does he keep the alveoli in focus when they're under a microscope? And he invented this little thing on a 3D printer that actually sucks the lung against the bottom of the slide. And then he videotapes it through a magnifying glass. And I said, do you have something that shows a disruption of or a bad distribution of tidal volume? And he said, yeah, this one. This one, you can see that alveolus in the middle. This is kind of what Dr. Van Kam was talking about. Only about half the lungs recruited here. So most of the volume is going to the already compliant open lung. You are getting gas to some of the collapsed alveoli, but they're collapsing on exhalation because you don't have enough PEEP in this picture. But this is really what makes babies so difficult to treat. I think it's why most babies get hurt, is a bad distribution of tidal volume. And now that we push the edge of viability down, in 1963, when John F. Kennedy's son, Patrick, was born at 33.5 weeks, he was a tiny little kid. He was only 4 pounds, 12 ounces. That's a whopper nowadays, right? But back then, that was the edge of viability. And it's your fault because you're so good at what you do. We pushed the edge of viability down. We have the best machines we've ever had and the best people using them. And now we backed ourselves into the corner where we're forced to sometimes treat these tiny, tiny little babies. And the reason we're forced to is parents love their children. And if they have a peri-viable baby, they want you to put it on. But again, these 22 weekers are really, really tough. And sometimes it doesn't work out. This is a baby that was used as a cover girl really for an advertisement of a hospital in the United States. I know this hospital really well. They don't use their jets. They don't use their oscillators. They've gotten really good at treating BPD and giving chronic lung disease babies their best life possible. So they're doing honorable work here, but I think they have a lot more BPD than they should have. And they used Autumn as the poster child for raising money for their research. And I thought that's really good. This was in a magazine when I was waiting for the dentist. And but then I read the small print. I thought, wait a minute. It says Autumn was born with a severe lung condition called BPD. I would argue that Autumn was not born with BPD. Dr. Jonathan Klein, who's treating the 22 weekers most successfully in the United States, said the reason I like getting the jet early on these 22 weekers is they're not injured yet. Babies aren't born with chronic lung disease. We develop it over time. And even Autumn would say, no, I wasn't. You know, don't blame me. It wasn't my parents. It was you guys. You stuck that tube down my throat. And so Autumn has really the right to ask, what happened? How did this happen to me? Why am I tricked? Why do I have chronic lung disease? And this is why I think. This is a slide I haven't used for quite a while, but this is, again, I'm the slow kid in the class. I'm not the smartest guy in the world. And for me to understand things, I have to put them in a way I get it, you know. And so I saw this very, very complicated slide on a normal alveolus versus an injured alveolus. It was all labeled. So I took all the labels off and I said, okay, as I learn things, I'm going to add the labels back. And I didn't really need to remove this one because in a normal alveolus, I always knew you should have air in the alveoli, right? If you ever got the wind knocked out of you, you know why you should have air in your alveoli. But I learned about the basement membrane, which is sort of that matrix that supports the growth of the type 1 cells and the type 2 cells. And it serves somewhat as a protective barrier around the alveolus. The type 1 cells make up the wall of the alveolus through which CO2 and O2 can pass. And you should have a nice layer of surfactant indicated by that white line, which is produced by these type 2 cells. They do all kinds of things. Most importantly for me is they produce surfactant. You should have an interstitial space that is not very wide. It should be very close to the capillaries for good VQ matching. You should have red blood cells not in the alveoli, but in the capillaries. And you should have alveolar macrophages that aren't very busy. At the Snowbird conference on high frequency ventilation, where I used to see Molly all the time, there was a doc named Parvis Manu who came from Los Angeles. And he taught me about alveolar macrophages. He said there's M0s, M1s, and M2s. And M0 is an alveolar macrophage that isn't doing anything. An M1 macrophage is one that's doing what it's supposed to do, which is attack things that aren't supposed to be there. And an M2 is one that's out of control because he's got too much to do. And that's when all kinds of bad things happen. And I said, what bad things? And he said, you'll figure it out. So I did. I took the other half of the slide and I took all the labels off. I said, what went wrong when the baby got injured? And I realized it kind of starts with sloughing of the bronchial epithelium. You may denude the basement membrane, so it's not going to be very supportive of type 1 cells, and the alveolar wall will be compromised. You might start to fill up with edema, which is protein rich, by the way, and can inactivate surfactant. You might necrose the type 1 cells, or apoptosis will be disrupted. Apoptosis, as you probably know, is the death of cells and then the replacement by new cells. And if you disrupt that, then you're in trouble, which has happened here. Surfactant gets inactivated by the protein-rich edema. And then something we used to call hyaline membrane disease, this inflammation of the alveolar wall from surfactant deficiency syndrome is what we call it for a while. Red blood cells, instead of being in the capillaries, get into the airways in the alveoli. And there's lots of cellular debris from all that sloughing of the bronchial epithelium and other problems that you've created. And there's fibrin that starts to collect. And then the macrophages get too busy. They become M2s and they release interleukins. I didn't know much about interleukins. I still don't. I know there's only one good one. Most of them are bad. I didn't know anything about tumor necrosis factor. I didn't think I needed to because anytime you put tumor and necrosis in the same phrase, it's probably bad. But what I did learn about interleukins and tumor necrosis factor is they are chemoattractants for macrophages, for neutrophils. So these neutrophils start to come in. Here you can see them busting through the wall. They somehow find their way in, and then they start attacking. They're trying to help, but they're these overactive white cells, and they release all the inflammatory mediators, which triggers inflammation. And that's when you do the inflammatory cascade, and the baby, by now the baby's probably getting close to death at this point. And you don't have to have air in their PIE. You can also have interstitial pneumonia fluid. Anything that pushes the capillary away from the alveolus is probably a bad thing. And so that's what I learned about why these babies are so tough and why they can get injured and why they can end up maybe like Autumn, trached. Another thing I learned in the animal lab from Dick Bland was when I worked, the first study we did with the jet was in 1993. And I said, tell me a little bit more about how the lungs grow. And he said, well, if we had 22, 23 weekers, which we didn't have back then, we weren't trying to save them at least. He said, the lungs don't really look like a sponge. They look like a bunch of grapes like this. And then alveoli are going to start to pop out. But inside is where the problems start. Inside you have these things called, God, why am I spacing it? Secondary pulmonary crests. And the secondary pulmonary, I said, well, what injures those secondary? He said, if you injure the secondary crests or you damage them, then the alveolus isn't going to grow at all. Or if it grows, it's going to be compromised. I said, what injures the secondary crests? And he said, well, they're kind of the roots of alveolar growth. And I said, then it's got to be FiO2, right? He said, no. What is it? No, I said, it's got to be, here's what I asked him. I said, is it volume or pressure? That's what I asked him. And I'm thinking I was smart. I said, it's got to be volume, right? Volutrauma. And he said, no. There's two things that it damages, and one is FiO2 and the other one is bad nutrition. No matter how small a baby is, you got to somehow get nutrition in them. And you got to get the FiO2 down. I said, to what? How much oxygen do you have to give them? This is back when we were doing 26 weekers. He said, if you're on 100%, you're doing damage right off the bat. But it's damage the baby can recover from. But you've got about a week to get them off 100% before you start to do permanent damage in a 26-weeker. And he said, as the baby gets smaller, it could be even worse. And he said by a week, you got to be on 70% or less. And really, we'd like to be down around 30% if we can, to avoid damage to the secondary pulmonary crests, because they are the roots of alveolar growth. And that's where the damage begins. So how do we ventilate these kids? If they're that tough, how do we do it? Dr. Allison Fraze in Kingston, Ontario, she did a lot of the work to get the Sensormedics oscillator approved. She worked with Charlie Bryan in Toronto, and they got the first big oscillator approved in North America. And she did a lot of research, and I Googled her last night while I was in my hotel. She's got a lot of studies done on oscillation, but she was kind enough to take a jet because she didn't think we were using it right. So she took a jet and she came back in 1994 to the Snowbird Conference, and she taught us what we were doing wrong. And finally, she said, you guys have to appreciate the differences between the oscillator and the jet, because that's going to be somewhat how you determine which ventilator is best for the patient, as we talked about at lunch. How do you decide if it's going to be an oscillator or a jet? And she said there's three fundamental differences between the oscillator and the jet. Number one is exhalation. The oscillator uses active exhalation. I don't know about the Draeger, as we talked about. I'm going to find out. But the Sensormedics certainly at that time was using active exhalation. It pushed the gas in and it sucked the gas out. The jet uses passive exhalation. It pushes the gas in, but it relies on the normal expiratory mechanisms to get the gas out. And she said, that's kind of a big deal, and it may help you decide which ventilator to use. The problem is airways lack structural strength. They tend to collapse. So you've got to give enough mean air pressure and PEEP to keep them open. If you combine that with active exhalation, here's what's going to happen. You're gas trapping, and you think we got to split those airways open. So you crank up your mean air pressure, and that's how she said we keep the airways open with the oscillator, is we make sure we have enough mean air pressure. And she and Charlie were the first to describe the phenomenon of choke points on oscillation. She said, that's great. You know, it keeps the airways open, then allows the gas to escape. But she said on certain patients, if they're hemodynamically sensitive, that mean airway pressure can compromise. So if you have a kid who's very sensitive hemodynamically, and you can very easily disrupt pulmonary vascular blood flow, then it may not be the right device. So here's what happens. You put the gas in, and if you start to trap gas, here's the problem. We've calculated that anywhere from 92 to 98% of the conventional pressure gets to the alveoli. And that's when you start to compromise capillary blood flow. And you can also create pneumos, but you got to be really, really careful when you're on a conventional ventilator or an oscillator. An oscillator, because that active exhalation can create choke points. Number two, she said, is eye time. You have to remember that the oscillator and the jet have different ways of delivering their eye time. The oscillator uses a fixed percentage eye time. That means no matter what your rate is, the inspiratory time is going to be a certain percentage of that cycle. The eye time changes as you change rate. She said that's the important thing, is that eye time is inherently linked to rate on the oscillator. With the jet, it is not. The eye time will not change if you change rate. It just sits there until you change it. And she said that's really important. Part of what we talked about in my first talk, I apologize for those who maybe didn't see it, but I will go over a little bit. Let's say you're on an oscillator and you're trapping gas and you're on 10 hertz and you're at a 1 to 2 IE ratio, which we're stuck with in the United States. You can get 1 to 3 here. And so you turn down the rate on the Centromedics oscillator to try to give more expiratory time. That's great, but you also increase the eye time because eye time is 33% of your IE cycle. 66% of the time you're sucking gas out, 33% of the time you're pushing it in, no matter where your rate's at. Does that make sense? And in Canada, of course, you have the luxury of 25% because you're able to go to a 1 to 3 ratio because you have better oscillators than we have in the United States. But it can complicate gas trapping, Allison said. And Allison is the first person to teach us that we don't have to be stuck on 420. 420 was the magic rate for a long time. That gave us a 1 to 6 IE ratio. But if babies get prone to gas trapping or they exhibit gas trapping, lowering the rate can really help. I was really happy to hear that you're not afraid of lower rates at this hospital. But as we talked about in the first talk, thanks to an excellent question by Molly, sometimes we get too enamored with these lower rates because rate still matters. An increasing rate sometimes is important because it provides your minute ventilation. Yeah, we use really low pips and very small tidal volumes, but they're not going to do the trick. Rate still matters. But if you go up to 360, you're still going to be at a 1 to 7 IE ratio. If you're at 420, you're going to be at 1 to 6. And that gives you more time for exhalation and reduces gas trapping. She said the third big difference is how you recruit. She said with my oscillator, I crank up the mean airway pressure, not only to keep the alveoli open, but to get them open. With the jet, you can give an occasional sigh breath, and then you can optimize inflation with PEEP. So typically you can use less mean airway pressure during the recruitment phase as well, if you use those sigh breaths effectively. But remember that the key word here is temporary. Let me change my pointer a little bit. I'm enamored with my new pointer. Temporary is kind of the key word. You only give them long enough to find optimal PEEP. And once you find optimal PEEP, then I think you may not need the sigh breaths. But as we talked about in this morning's lecture, depending on the baby's pathophysiology and pathogenesis, sometimes you may want to give 1 or 2 breaths if the baby's prone to atelectasis of the new alveoli that are growing tremendously. Babies grow about 3.3 alveoli per second. And if they're atelectatic, then maybe 1 or 2 breaths wouldn't hurt. But generally, we don't use just the mean airway pressure to get the lungs open. We use it typically as sigh breath. And that could be an advantage for how we recruit and stabilize with less mean airway pressure. So based on all this, when would you use which ventilator? When would you use non-invasive? I think if you have a baby who's intubated, your best bet is to probably ask yourself 3 questions. The questions are, number 1, is the patient well enough for non-invasive ventilation? Nasal CPAP, high flow nasal cannula, whatever you use. Or is the patient sick enough for HFV? But more and more now, people are tending less to spend a lot of time on conventional ventilation because they're asking themselves these 2 questions. The third question, I think, this is one that I added from what somebody taught me, is the patient improving on conventional ventilation? I don't think the jet or the oscillator is always the answer. If a baby's doing well on conventional, and you've seen this type of baby before, and you can see he's improving and you're starting to wean, I wouldn't waste a high frequency circuit. It's only when he gets stuck or he's going the wrong direction that you may want to think about it. But those first two questions will really help you, I think. And I think the best bet is if you can answer number one. Yeah, he's well enough to be on nasal CPAP. That's probably the least invasive form of ventilation that we do, because you're not even intubating. So I thought, well, how safe is it? And there is a doc who's now retired back in Canada again, and it's Haresh Kirpalani. But when he was in Washington, D.C., he published a study in the New England Journal of Medicine. And he wanted to compare non-invasive positive pressure ventilation with nasal CPAP. Is it better to give breaths through the nose, like Dr. Ram is doing in California? Or is it better to just give nasal CPAP? And he wanted to compare. And what he determined in this study, and there were some problems with the study. The biggest problem is they didn't use the same systems. So they don't really know. But regardless of what system they used. You were? Oh, wow. What system did you use? Oh, okay. Gotcha. Uh-huh. That is, yeah. I like that one. But what he found was that there didn't seem to be a difference. There was a slight advantage to just giving nasal CPAP, but there was no statistically significant difference. And when I looked at this, what shocked me was there was still BPD. I didn't know that. I thought if a baby was on non-invasive, there's no such thing as BPD. And Dr. Marty Kessler said, sometimes Evan, I think we're misled by these terms. You know, we see these warm terms about continuous positive airway pressure, high flow nasal cannula, non-invasive, they're all good, but they still have those key words, pressure, flow, and ventilation. You still got to keep the alveoli open and you got to move gas in and out of the lungs. And he showed this slide in Edmonton when we were at that conference. And I took a picture of it. He said, you can make your own. I said, no, I like yours. And he said, you know, you still have to have an open lung. And sometimes we're so enamored with avoiding intubation that we forget that sometimes it might be better to intubate, give a little surfactant, some gentle protective ventilation, because babies can still get injured even though they're not intubated. And there was an RT back in Toronto that said, yeah, we had this 24-weeker that came in and he just did so well on nasal CPAP. We didn't intubate him. But then after about a week, he started struggling, and we're doing everything we can. We're moving things around. We're changing systems. We're changing settings. And we just struggle with him for a long time to try to keep him stable. 24 days. The same number of days as his weeks of gestation. And that finally, after 3 weeks, he said, just over 3 weeks, we decided we're going to intubate because he was too unstable. We couldn't keep him stable. And we got a blood gas, or we got an x-ray, and the first x-ray revealed chronic lung disease. And that kid had never been intubated. And it looked like the same kind of chronic lung disease we see on ventilation. And one of the guys that I met early on at the Snowbird Conference was Jack Emerson. He's one of the guys that developed the iron lung, and he called surfactant deficiency syndrome sticky lung syndrome. He said if the lungs collapse, they stick together, then you pop them open and there can be some tearing. And I don't know if that's what's happening, but you do have to keep the lung open and inflated because babies can still get injured. So the second question might be, is the patient sick enough for HFV? And then you got another quandary. Okay, we're going to do high frequency, but which one should we use? And I didn't know, so I went to a hospital that trained people around the world how to use the Sensor-Netics oscillator. And for a long time, they had this incredible 3-day class that you could take at their hospital. And you'd even take the oscillator apart and put it back together, and you do animal labs and the whole bit. And some friends of mine were RTs that did a lot of the teaching down there. So I went down and I asked the physician and 2 RTs, you've got both the oscillator and the jet. How do you select which one to use? They said, well, we love the oscillator for uniform non-compliance. If a kid has collapsed, has RDS, hasn't responded to surfactant replacement, we feel there's nothing better than the oscillator at recruiting what we call the architecture of the lung. You crank up that mean airway pressure and you get the tree back, basically, tree grows. And we also ask ourselves those 2 questions. Is he well enough to be on nasal CPAP is sick enough to be on high frequency. So we'll start the oscillator as soon as they start struggling on conventional. If we can't get them under control, we'll start the oscillator right away. And they said the jet, we learned because of when the oscillator didn't work as well. It was usually on air leak syndromes. They said you came down with your test lung, you stuck it underwater, you set the PIP at 30 on the jet and 20 on the conventional. And even though the jet was on 10 centimeters of water more pressure, there was no leaking through the air leak. And so we tried it with the oscillator and we saw a continuous stream of smaller bubbles. It was better than conventional by far, but it wasn't as effective at the jet as the jet. You can also see how ineffective the jet is at reversing atelectasis. Those breaths are so wimpy that by the time the pressure that you've set on the jet reaches the alveoli, it's only, Allison Fraze predicted 5 to 7% of the set value. In other words, if you set at a PIP of 30, you're delivering less than 3 at the alveolar level. So the jet will not reverse atelectasis, but it's really, really good for air leaks. You can use the side breaths on the conventional to reverse atelectasis. We really like it for secretions. They said that double helical bidirectional flow we talked about in my last talk. Gases going into the lung, coming out at the same time. The beauty of the oscillator and the jet is they kind of do internal chest PT. They're always vibrating, but the jet, it has the ability to sweep out things like blood. In fact, the kid that turned me around to the jet, I didn't like the jet when I first started using it. And we had this meconium aspiration kit, and Dr. Harris wanted to put the kid on the jet. Brand new, we were the first hospital ever to use it. This was in 1983. Most of you weren't born. Ruben was probably just a teen. He was a boy. Yeah. Molly was still in body size. Anyway, he wanted to put the kid on the jet. He said, "What do you think of?" And I said, "No." He said, "Technology has provided us with a more efficient means of moving backwards." I quoted Aldous Huxley. That's Aldous Huxley. He said, "What do you mean by that?" I said, "Well, we have all this technology, but we put the first 3 kids we put on the jet died, and it was not a happy death. You know, we gave the parents hope, and then the baby died." And he said, "Well, we're going to try it anyway." He said, "Well, what would you do?" And I said, "What I would do is I would sedate the kid a little bit, take off all the technology except for his ET tube, give him his first bath. He's never had a bath. Wrap him in the prettiest quilt that a foster grandmother ever made, yank the tube, wipe his face, and let mother rock him slowly to sleep forever." And he said, "We're not going to do that. We're going to try the jet." They put it on, the kid got better, and this was the reason why. I digress a little bit, but that's how I got hired by Vanel. I felt so bad about encouraging them to let this baby go because he was ball valving, air trapping, had 3 pneumos, was digressing, that I did Grand Rounds presentation for docs in the Valley. And it's the first presentation I ever gave. And I had x-rays and the whole bit, and somebody videotaped it. And I got the video to Bert when he was hiring somebody, and he hired me. I said, "Why did you hire me?" You know, in the video, I expressed my reluctance to accept the jet. He said, "Because you're a convert. You believe because you were convinced, not because you were told to. And that's a stronger advocate." So I said, "Okay." So he hired me. That was back in 1989. But this was why that happened to this little boy. We mobilized the secretions and they came out. We really like it for hemodynamic compromise. Anytime we're squeezing on the heart, the folks down at this hospital that train people, they said, we trained 2 respiratory therapists to do ultrasounds. And we would get these kids that were given all kinds of stuff to maintain blood pressure and hemodynamics. And we thought this is too much medication to try to maintain these things. Something's going on. So they did a CT scan or an ultrasound, and they would look at the heart. The heart looked fine. They would drop below the diaphragm because the inferior vena cava looked fine. But when they dropped below the diaphragm, the inferior vena cava was sometimes swollen 3 times its normal size from blood backed up, trying to get into the thoracic cavity. And that's the problem with the oscillator and the jet, is you don't always get the full picture on X-ray. You know, it's harder to see hemodynamic compromise when you're wiggling around a CPAP than it is on a conventional when, you know, you get worst case scenario. So so what they did is they saw this, and so they switched to the jet, and that took a lot of the mean airway pressure off because the jet always uses less mean airway pressure distally, and the problem went away. They stopped vasopressors and things like that. And then gas trapping, that's the big use now, especially with these micropremies. And it's because of that advantage of being able to give a 1 to 12 IU ratio. And all this stuff they learned when the oscillator failed. So I think there's a place for both, but I was here to talk to you about the micropremies. So let's just touch on that. I'm not going to go into a lot of detail on these slides because I've showed them here before, but I got some brand new ones for you. But this is important. Dr. Jonathan Klein, there's things he's doing that I disagree with. The strategy, for instance, on micropremies, he's kind of leading the charge in the United States for the micropremie, and the JET is his primary tool. But he's having incredible success with 22, 23, 24 weekers. And one of the things, for instance, I disagree with him on is he keeps babies intubated until they reach their gestational 40 weeks. So if he's got a 22 weeker, that baby will be on for another 18 weeks or something like that, even if they're doing well. And most people would extubate. And so if you look at a paper that they published recently, you'll see that every kid had BPD, and that's because of how we define BPD. You know, they're still intubated and they're still on oxygen, but it's usually only like 24, 25%. But I would try to extubate those kids earlier. But some of the stuff he's doing is just remarkable. And I really respect this guy. And these are his results. This is from a poster he presented at the PAS when it was in Toronto, 2018. And what he said is we found that we were having a 47% survival in 22 weekers and a 70% survival in 23 weekers. It just got better the longer the baby was able to stay inside mom, which is the safest place until it becomes unsafe. And then it occurred to him that those were 2004 to 2015 data. And he thought, you know, we didn't have a protocol in place and we didn't have a team in place until 2006. So he said, I adopted the strategy of mission control when the United States landed a man on the moon. And that was, we demand two things, teamwork and competency. We're going to work as a team. Everybody matters. Physicians, nutritionists, nurses, respiratory therapists, pharmacists, everybody's got to play a role in this. And we have to be committed. If you're not committed to this, then you can't be on the team. And then what he said is, we may not be successful, but just like mission control, we have to give it our best shot. And then if we fail, we fail. But we demand teamwork in the team, and it took him 2 years to get all that stuff in place. So he said, once we had our protocol and our team in place, we decided to move everything up 2 years, because that's how long it took us to get running on all cylinders. And we ran the same numbers the same way, but all of a sudden we jumped up to 59% survival and 78% survival in the 23 weekers. And I just saw him do a lecture about 6 months ago, and he talked about a cohort of babies in 2020 where they had a 70% survival in 98 kids, 22 weekers and 82% survival at 23 weeks. And I always asked him, well, survival is one thing, but what about morbidity? And their incidence of IVH is, there's no statistically significant difference, and it's pretty low. It's around 17, 18%, which, you know, may sound high, but for babies this fragile, it's not bad. He said, we'd like to have no IVH at all, but yeah, we don't want to just have them survive. We want them to play the piano and solve the world's problems. You know, we want healthy babies too. So we're really working on that. But anyway, I asked him, so how are you doing it? And he said, well, we're doing it mainly because parents love their babies. Some of these mothers have had 2 miscarriages, and they finally get a peri-viable baby, and they say, oh my God, you know, we have a nursery we've never used. Could you please send my baby home with me? And so that's when we decided we've got to try. And the problem we found very early on was these are the smallest airways we've ever treated, and they're very resistant to flow. It's easier to get gas in than it is to get gas out on these babies. So we go out of our way to avoid gas trapping. And we do that, we own 14 jets. We're part of the Dove trial, which is the trial to get the oscillator from Draeger approved in the United States. But he said, if the baby's under 26 weeks, they will not go into the trial. We'd rather have a baby go home with mom and dad than go into a randomized controlled trial. And we're very successful with our jets. He said, so we like it because of this gas trapping problem. We can give 1 to 12 IU ratios. We'll usually run at lower rates, anywhere from 240 to 360, which is what you guys are doing here. I'm really excited about that. But remember, don't be afraid to go up on rate if you're struggling with, you know, babies. And he said any kid under 26 weeks goes on the jet if they fail nasal CPAP and IV. And I said, how soon do you get them on? He said, our goal is within 10 minutes of life. We give them a brief trial on nasal CPAP. We're right there in the OR, and I'll show you a video of that in just a second from a hospital in Canada. But they do the same thing as this hospital in Canada. And they said if they're struggling, we'll switch to the jet. We want to get them on before their lungs are injured. And this is the study they published. And if you look at this study, you'll see that every kid had BPD. That's because he keeps them on the ventilator, I think, too long. But it has been published. If you ever want that, I can send it to you. So let me tell you about the Canadian hospital and the Vaughan network. This is a hospital that I'm pretty close to these guys. There's a few hospitals in Canada. Well, most of them are my favorites, but this is one. I love Royal Columbia. I love all. I don't want to pick my favorite child, right? And then Sunnybrook Hospital. But I was able to look at Sunnybrook's data from 2015 to 2016. So anything on the left of the hash is number of hours in 2015. Anything on the right is number of hours in 2016. And you can see a trend here. What they're trying to do is, you can, well, I think that spotlight, I'm going to put the spotlight, there we go. You can see that from 2015 to 2016, look how much their high flow nasal cannulas went up, many, many hours more. But everything went up non-invasively. They're trying to avoid intubation. And they can see just how aggressive they got from 2015 to 2016. And then if you look at their data on invasive ventilation, where you have to innovate, look at their conventional hours. They cut 1,000 hours off. They're asking themselves that question. We're not going to dink around on conventional until the baby gets hurt. We're going to ask ourselves, is the baby struggling? We'll switch. And I was pretty excited because in 2016, I still have a little bit of bias towards the jet, but they said our jet hours finally exceeded our oscillator hours. And Rob Graham, my friend there, said that in 2017, same thing, our numbers even went up more. So we're pretty excited. But he said, we love both machines. You know, it's a lot easier to start off on the oscillator. So often we'll do that. And then we have failure criteria where we'll switch to the jet. But that's it. I think it's reducing those conventional hours is really important. And I think the reason this happened is really because they're getting smaller babies. I'd like to see what their data are now, like in 2021 at least, because of that 1 to 12 IE ratio. They can avoid gas trapping. He said that was the biggest problem we had early on with these tiny babies, was gas trapping. So we compare ourselves to everybody else. This is Sunnybrook on the left, and he said our chronic lung disease rate was 8.1%, and the rest of the Vaughan network was 31%. So we feel like we're doing something right. So this is what they do. They get a baby in, and you can see what happens. You got to give the baby a shot. There he is born. They wrap him in plastic. Oh, sorry, Siri, I wasn't talking to you. I wonder what she was going to say. But here comes the prawns. So they kind of weigh and they see how the kid responds. And then you're going to see something right down here that will help them. They're going to have to stimulate the baby. You'll see somebody reach in and start to tickle the baby to try to get the baby breathing more. And so they have this criteria for failure of nasal CPAP right off the bat. So here comes a little hand. There's some volume on this too. I should have turned it on. It enhances the drama. There's the little hand. See it coming in. Come on, kid. Let's get going. So they try really hard to avoid intubation, but you know, if they can't do it, then they'll boom. So there you go. So what are the patient management strategies for these kids? I've done some other things, right? You remember the slides I did? You've probably seen them a million times, Molly, where I bring up PIP, PEEP, rate, and I time, and then I say on the conventional, you do this. I decided to try a different approach. I want to simplify it. People are very busy in NICUs, and so I decided just to try to break it up into two easy categories. One is, what does the jet do? Well, it's responsible primarily for ventilation. Think of it, if you're used to the oscillator, as the amplitude. It's the size of your breath. The conventional ventilator is primarily for oxygenation. It's your mean air pressure. The jet only adds about 3 centimeters of mean to whatever you're doing. So most of the mean air pressure is going to come from the conventional. And the conventional really has three roles. One is to give fresh gas for spontaneous breathing. I didn't include that here. But the jet uses very low flows. It only uses about 4 to 6 liters per minute of flow. So it's a very low flow system. But the baby can breathe spontaneously on the jet, but he needs a gas source to breathe from. And that's a continuous flow through the conventional circuit. But the two main things the conventional ventilator does is it gets the lungs open and it keeps them open. So the conventional ventilator is primarily for lung alveolar recruitment and alveolar stabilization. So here's the way I've decided to simplify it. I'm going to give you the post-it note fundamentals of patient management. I made these slides on the plane last night. I don't know if they're going to work. Let's try it. So here's your first post-it note. Number one fundamental is managing oxygenation. I think a good way to look at it is establish FRC. Get the lungs open and keep them open. That's going to be the hardest thing to do because of what we talked about. Where does the gas go? And then maintain the mean air pressure. Don't be too afraid of too aggressive at weaning PEEP right off the bat, because that's what most of your mean air pressure is coming from when you're on the jet, is from the PEEP on the conventional ventilator. Because you're not going to be given very much rate, if any at all. So in summary, I would say open the alveoli and keep them open. That's your number one goal for good oxygenation. I will argue that CO2 is going to improve too if you open the lung and stabilize it. But right now we're talking about oxygenation. Your primary controller for oxygenation is PEEP. Secondary control is conventional breaths. As we talked about this morning, sometimes if you're struggling with the kid, you may want to give 1 or 2 breaths. Or you may have to go out and give 4 or 5 breaths for a little while you try to find optimal PEEP again. But the key is finding optimal PEEP. And once you do, you probably don't need the side breaths unless the baby's prone to persistent roving atelectasis. I'll keep that one up there for you. Hey, it's working. There's my second post-it note. Managing CO2. Your primary controller for CO2 has been, ever since we started using PIP, small changes in PIP yield very dramatic effects on CO2. We found that a change in PIP on the jet, there's 2 things that will remove CO2, and that's frequency and tidal volume. The amount of CO2 you're going to be removing is roughly proportional to frequency and tidal volume. With the jet, it's roughly equivalent to tidal volume squared. What that means is every change on PIP that you make is going to have a squared effect on CO2 removal. I didn't realize that early on, and with Dr. Harris, my clinical mentor, the 3rd baby we ever ventilated, the kid that we saved, we were on a PIP of 32 and we got a CO2 of 76. And I said, Tom, we got to go back to conventional. This jet isn't working. Let's go back to something we know. He said, it's supposed to be good at removing CO2. Look at the animal data. And I said, well, our patient data on the first 2 isn't very good. He said, well, what if we go up on the PIP? And I said, yeah, I think that'll work. I didn't know about tidal volume squared, but every change I make on PIP is going to happen anywhere from 240 to 420 times a minute. So it's a dramatic effect on CO2 removal. So he said, well, what should we go to? And I said, how about 40? We went from 32 to 40. And because we were scared on a machine we didn't totally understand. And we only waited 12 minutes for a blood gas because, again, we were scared and we didn't really understand the device. And the CO2 came back 17. So too much, too fast. We found that PIP is a very, very effective controller of CO2. When PIP is no longer working, then I would think about I time. Maybe change the I time and change it in small increments. The first time I instructed a physician to do it, I went from 0.02 to 0.034, which is the shortest to the longest I time. Didn't sound like much, 24 thousandths of a second, or 20 thousandths of a second to 34 thousandths of a second. But again, it's that rate, minute ventilation. And we drove the CO2 from 126 down to 29 in 30 minutes. So be careful when you change I time. But typically what Jane Pillow taught us in Australia is when PIP is no longer working, think about I time. The baby may have a longer inspiratory time constant, and even on the jet that matters. So look at diseases where a baby might have long inspiratory time constants. And that's when you go up on the I time. And I said, well, when do you consider PIP not working? And she said, usually mid-30s. If I get in the mid-30s or high 30s, I should be blowing off CO2 with the jet because it's good at that. If not, I'll start to at least think about I time. And then remember, the rate still matters. Molly brought up such a great question this morning. And I hadn't thought about it in a long time until she inspired me to do so this morning, and that's that the rate still matters. It's your minute ventilation. So you may want to change that if necessary. Sometimes we are so excited about lower rates that we may go too low, but I'll keep that up. Hyperinflation, fundamental number 3. Try to avoid it in the first place. You know, I think we all do. Nobody wants to hyperventilate their kid, but especially with the micro premiums, the smaller a baby gets, the harder it is to resolve gas trapping, inadvertent PEEP. So try to avoid it. Make sure you have enough PEEP to maintain airway inflation. Sometimes people see gas trapping and it's gas trapped on the distal side of floppy airways. So they turn down the PEEP, which makes the problem even worse. Sometimes you need enough PEEP to stabilize airways. Otherwise, the gas can't escape. But our number one way of resolving gas trapping, if you've done everything right and you have enough PEEP, is to lower the jet rate. That's where the jet gives you that advantage of a long expiratory time and a very, very generous IU ratio. Okay, number 4, avoid the CMV trap. This is something Alison Fraze taught us in Kingston, Ontario, Canada. She said, do CMVs improve oxygenation? She said, if they do, you probably don't have enough PEEP. She said, this is what I mean by that. I asked her what she meant by that. She did this in her rabbit lab. And she said, what happened is I would take away the sigh breaths on a baby, on a rabbit that was oxygenating well. And I would watch in 5 minutes or less if he desaturated. I thought, I don't have enough PEEP. So there's no way a baby would, he's still on the jet. I just took away the sigh breaths. And she said, there's no way a baby would desaturate in less than 5 minutes just by losing an occasional sigh breath if I had enough PEEP. So I would give the sigh breaths back and I'd raise my PEEP by 1 to 2. And then once the baby sat for stable, I would go back to CPAP. And once I could go to CPAP without losing oxygenation in 5 minutes or less, then my PEEP was probably there. But don't think that, oh, he likes the sigh breaths, because that's when he really, all you're doing is you're adding mean air pressure. But as Jane Pill, or not Jane Pill, but Alison Fraze taught us, you know, if the baby likes the CB, likes the conventional breath for oxygenation, you probably don't have enough. Make sense? Okay. God, my post-it notes are different sizes. I'm gonna have to work on that. I guess they make them in different sizes. CMV breaths. Number 5, fundamentals of patient management. Number 5, CMV breaths. Well, if they can, if you get into a CMV trap, when are they useful? And I would try to avoid them altogether for air leaks. You saw when I stuck that lung underwater that they can really aggravate the air leaks. But you may want to consider something that I first was enlightened to by that woman sitting right there, Molly Sation. She probably remembers this. It was in Washington, D.C. at the PAS conference. Molly came to me and I was in the booth at Benell. I hate the booth. I'd much rather be going to the lectures. And Molly said, you got to come to this lecture with me. It's an anesthesiologist who doesn't think we're recruiting kids properly in the NICU. And I knew Molly. I knew she'd really give it to him if he was wrong. But I couldn't go with her because I was stuck in the booth and Bert and Dave were at lunch. So I said to Molly, would you come back and tell me what you learned? And because she's the kind of person she is, she did. She came back. And she said, Evan, it was amazing. He talked about how we recruit kids. Sometimes we give this high pressure, long eye time breath. And I don't think that's a very safe way to do it. So I'm going to tell you what I learned from Molly, the anesthesiologist, Jane Pill, and others in just a minute. But remember this low PIP with long eye time. PIP is only dangerous if you give too much. But if you just give a little, it's a little bit safer. And eye time is one of the worst things for an air leak unless you're at a very low PIP. So keep that one in mind. And then weaning from the jet. What I found is the best thing to do is probably wean FiO2. Make sure your FiO2 gets down. You guys can decide how much FiO2 you want to get to before you start weaning PEEP. But don't be too afraid of PEEP and mean air pressure. Try to get your FiO2 down first. And then we used to go from the jet back to conventional ventilation, low rate, low pressure settings on the conventional, then wean the baby off the conventional. And it was different physicians that came to us and they said, why do you go from the jet to conventional to get to non-invasive? And we said, because that's the way we've always done it. They said, that's a really bad answer. And they said, well, we want to get rid of that conventional arm of your weaning strategy. I said, well, if you think you can do it, teach us how. And what they found is the best way to be successful extubating from the jet to non-invasive is to look at the level of the last recorded mean area pressure. In other words, if you're on the jet and you're at a PEEP of 5 because you weaned everything, your mean is going to be about 8 because the jet adds about 3 centimeters of mean to whatever your PEEP is. So if you extubate that kid to non-invasive at the equivalent of a CPAP of 5, you're probably not going to be as successful as if you went closer to 8. So I sent it out to my ad hoc advisory committee, and a number of people wrote back. I said, if you're on these settings, where would you put the kid on nasal CPAP? And everybody said, tend towards the last recorded mean air pressure. It's hard to go from having the tube in to having the tube out. And sometimes we don't know what we're really doing through those prongs. And you're going to be more successful. Number 7, avoid the 2 biggest mistakes: starting too late and weaning too fast. That's probably number 1. It should be number 1. These aren't in any order of importance because I think this one's about as important as anything. Don't wait until a baby's. I think rescues are exciting, but avoiding the injury in the first place is more fulfilling somehow. And then don't wean too fast. But one of the discussions we had at lunch with Eamon and Michael was sometimes we stay on the jet too long. So don't be afraid to wean. Don't be afraid to extubate, but don't be too aggressive. Where that usually happens is people aren't comfortable with the jet. So they try to get back to something they know better. They'll try to wean quickly to get off the jet. And then the kid just gets sick again. So be careful with that. Okay, last thing I want to talk to you about is a couple things. How do you do that? How do you do all this? How do you avoid hyperinflation? This is one of the bags of tricks items I'm going to throw in for you. Again, Dr. Klein, he said, my biggest strategy, my most important strategy with the micropreemie is to avoid hyperinflation. It's a lot easier for me to reverse out electrolysis than it is to resolve air leak. And unfortunately, we learn that through trial and error. Once a kid gets gas trapped and they're that tiny and their airways are that resistant, it's hard to resolve it. So we try to avoid it in the first place. And how do you do it? Well, this is a sample case study. Is anybody in here a fellow? Okay. I've got a fellow in this, and then I'm going to use you, Ruben, as the old timer. Even though he knows the jet really well, I'm going to pretend that he's the old timer. So the new fellow comes in, and they say, okay, we got a kid that is going to go on the jet. So they asked Ruben, that's you, Ruben. They said, the fellow says, I'm going to seek counsel from Ruben.
Sorry, could
Well,
you say that again?
yeah. How old is Ruben? No. So she said she didn't know. What are initial settings? I'm kind of new. I'm new to the jet. And Ruben, although he would never say this, is we'll start at 420, PEEP of 5, set enough pip for a wiggle, set a PEEP of 6. And the fellow looks at that rate of 420 and says, why 420? And Ruben says, well, because that's what we do here. But I know for a fact that you don't do that here, so that's okay. Well, this is going to lead to gas trapping, most likely. That's probably not a very good idea. I learned this the hard way. I was actually the old attending, not Ruben, because I thought 420 was the magic number. You should never stray from 420. And one day I started learning from physicians that they were using lower rates. In the old days, everybody used 420. We never strayed from it. And this doctor called me, Dr. Carol Wagner from Charleston, South Carolina, in the United States. I've known Carol for a long time, and she called me. This is a perfect month to tell you this story, October. She said, Evan, I got this kid. I don't know what to do. I'm trapping gas like crazy. I've done everything. I've got optimal PEEP. And I said, well, have you tried lowering the rate on the jet? She goes, no. I said, why? And she said, because I can't. And I said, why? And she said, because I'll turn into a pumpkin. October. And I said, what do you mean you'll turn into a pumpkin? She goes, you guys told us the rate of 420 is magic. You should never change the 420. I said, we were, what's that word? Wrong. We're learning from people like Carol, like you guys, that you can lower the rate. And so she lowered the rate, and that's what finally got rid of the gas trap. So she said, it's really diagnosis based, Carol has since learned, and we learned together. It depends on the baby's disease, where you use the rate. Don't be afraid to go down on it, but don't be afraid to go up if you need to. But remember with micropremies, typically the smaller the micropremie, the more you're going to tend towards 240 or 300. Dr. Klein starts the smallest babies on 300. If little bigger babies, and he's got criteria for this, I'm going to send you his protocol. He starts on 360, no, 300, 360, and only the babies 1,000 grams or more will he start at 420. So, and I'm not saying that's the best way to do it. That's just what he does. But it makes sense to me is to avoid the gas trapping in the first place. Sorry, Ruben. And you remember this, we talked about this a little bit. It's especially important in the micropremies. Remember that, eye time is a little different on both machines, right? Okay. Then the last one before I end here is recruiting and stabilizing alveoli and airways. Notice I said on that slide, alveoli and airways. You don't have to just keep the alveoli open. You got to keep the airways open. Otherwise, you'll start to get regional gas trapping, gas trap behind collapsing airways. This is what we try to do with the conventional, with the jet. We use the conventional to get the lungs open. And then we use PEEP to keep the lungs open so that we can relieve stress. But if you're still giving those conventional breaths, especially at a rate of 10, you're going to strain the alveoli over time. It's like bending a paper clip is the example I used during the Q&A on the last lecture. With a stick, you're going to bend it, it's going to break pretty quick. But with a paper clip, you're going to bend it, you're going to strain it over time, and ultimately that paper clip will break. So the alveoli, which are constantly being inflated by positive pressure, that's not how we breathe. Everybody in this room is breathing with negative pressure. It's a normal way to breathe. Iron lungs make a lot more sense in a ventilator because they breathe like we breathe, but they're very cumbersome and they're impractical, so we don't use them. But so we got them open, we keep them open, and then we start the jet. And you're going to be about as gentle as possible. That's our goal. Relieve the stress and strain on the alveoli. But this woman came along. What was you're holding there? It was like #1 dog, best duck in the house. There's a little award here. It's small in size, large in stature. And this woman certainly deserved it. I'm going to zoom in on that. Let's see. Still too slow. But I've known Molly for a long time. She means the world to me. And this was that conference I was telling you about, where she came to me to tell me about this new strategy. And here's what the anesthesiologist said. He said, in a NICU, if you're trying to recruit a kid, you give a side breath to try to sustain inflation. If you get up here in 28, 29, 30, 31, and the longer you go on the eye time and the higher you go on the PIP, the more volume you give, the more dangerous it's going to get. That's what's going to kick you up into that injury zone. And what he said is, what if you gave, he said in an anesthesiology department, and Dr. Michael Trainer, a friend of mine who's teaching me about the jet in the OR at BC Children's, I said, what do you do if you're in the middle of a procedure and the kid's on the jet and he starts to desaturate? He goes, I give 3 breaths with the resuscitation bag, no more than 10 centimeters higher than my peak. And I'll hold it for 20 seconds. I'll give 3 of those. So it doesn't hurt to give those low pressure, long eye time breaths. And that's what the anesthesiologist said that day in Washington, D.C. And so what he's talking about is, what if you give a 3-second breath, but with a very low PIP? But to me, it sounded kind of dangerous because, what if you have to raise your peak, which you probably will, to stabilize? Well, the beauty is you're using a low PIP, so you're still below that injury zone where you're not going to hurt the patient. And plus, if you can get rid of the conventional breaths, then you're on CPAP with a wiggle with the jet. Now you're going to be so far away from there that you're going to be okay. You're not going to injure the patient. Why did I put that in there? Let's find out. Oh, that's 5 hertz. 300 breaths per minute. That'll still give you a 1 to 9 IU ratio. Yeah, that's what I was saying. So on 300 breaths, you're going to have a 1 to 9 IU ratio and plenty of time to get gas out. And this is Jane talking about it. Let me see if I can make sure that I have the volume on. This is one of the women that taught me about it. It's always the women that teach me this.
So during SIMV and assisted control, because you're regulating the inspiratory time and not permitting those extended sighs, one way to get around that is to allow a little bit of a breath hold at the end of each breath. And that allows for the air to recirculate around the lung and to ventilate areas of the lungs that have got slower time constants that are not inflating as quickly as some others.
Time for the volume to be distributed to alveoli that have longer time constants that aren't inflating as quick as others. A little bit of a breath hold. what she's talking about really is the pendulum flow. Basically what that says is if you can hold that breath hold for a little while, the alveoli will start to share their volume with adjacent alveoli that aren't inflated. The pendulum flow works something like this. You hold the breath, this guy's got all the volume, so he'll actually share. There'll be a little bit of ventilation because they're friends. Alveoli are like people. They need friends around them to help them out. Ruben and I are friends, but the difference is they need stable friends. One of us is unstable. I won't tell you which one, but it's me. But we're good people, but we would be bad alveoli because they have to be very stable. And they know that. So it's alveolar interdependence. They rely on one another to support them. So here's what we're talking. I showed this video for a long time, and I always showed it to show the importance of PEEP. But then it occurred to me one day in this study by Art Slutsky, or in this video from Art Slutsky in Toronto, he's given a 3-second eye time. So watch this video for 2 things. Watch what happens when you don't have enough PEEP versus when you do have enough PEEP. Then watch what happens once he gets enough PEEP when you give a 3-second eye time. Pretty remarkable. So on these first 2 breaths, he doesn't have enough PEEP. So the lungs collapse at the end of exhalation. Right here, he turned his PEEP up to 15. And now the lungs don't collapse on exhalation. Now watch for the duration of the eye time, how the lung keeps popping open. See that? Pop, pop, there it goes. Some of them are opening at 2.8 seconds. I'll provide a sound effect. Got it. So that's the beauty of a 3-second eye time. Now, PEEP is still really important. I cut it off, but he takes away his PEEP after that and the lungs collapse again. So I think that video shows, I think the value of maybe a 3-second eye time with a low PIP. It just gives more time for the volume to be distributed. And it's a good way to recruit. So we wanted to test it out. These are my last slides, and then I'll be done. I did a study in Seattle with Rob DeBlasi in the animal lab. These poor rabbits have given their life to help us save babies. So we wanted to use every part of the animal. And so we took the lungs and we created a bunch of pneumos just by putting holes in it with a needle. So these are the rabbit's lungs underwater. We set the jet PIP at 30, the conventional PIP at 24. Imagine we're trying to recruit this kid. And we only have a nighttime of 0.4. So an old traditional way of ventilating. We're on a PEEP of 8. And watch what happens. Every time the breath comes, there's a little bit of bubbling all the time. But there's the breath. You can really see when that sigh breath comes. There's the sigh breath. So a lot of bubbling out those leaks we've created over there. And so we thought, well, is there something to this strategy where you give a low PIP with a longer eye time? So we set the PIP at 15, kept the jet PIP at 30. We've even increased the PEEP a little bit. So you will see a little bit of bubbling constantly, but just out of one little spot right over there. There's the breath, believe it or not. Okay, it goes away. There's the breath right there. So there, it's hard to see something, but there's a little bit of bubbling. That's the same animal, same air leaks, just different levels of PIP and eye time. So I think it's a fairly safe way to recruit if you do, if you're careful. Now there are some keys to this. Before I show you that, I think the key here is if you're going to do this longer eye time, lower PIP strategy, make sure you turn the PIP down. You don't want to give a 2 or 3 second eye time with a high PIP. There was Jane Pillow emailed me and she said, Evan, I had this kid I couldn't ventilate, and here's what I did. And she used a 2 second eye time. And she was 6 centimeters above her PEEP. This is what finally worked. A long eye, 2 second eye time with the PIP just above my PEEP. And then I was in Norfolk, Virginia, and Dr. Jamil Khan had a post-op gastroschisis baby, and we couldn't get the lungs open. I told him about the strategy, so we tried it. The PEEP was set at 14. So we set the PIP at 20, 6 centimeters above, and we set a 1.5 second eye time. You don't necessarily need a 3 second. You don't even need a 2 second, maybe a 1.5 will do it, but it's your clinical intuition that will guide you. But it's something to really think about. I think lowering the PIP is the key, and only temporary while you find optimal PEEP. So here's my take-home checklist. I heard a horrible statistic on National Public Radio, which is kind of like I think it's the CBC up here. It's good radio. And they said 90% 60 minutes after a lecture, people will forget 90% of what you said. And I know that's true. It happens to me all the time. So I summarized the 10% you need to know here. Number one is this is something I didn't have to tell you. Moms and dads love their tiny babies. I think they can have good outcomes. Not always. We're not perfect, but we're getting better and we're learning along the way. And I will share with you everything that I have when I can. I think one of the keys on these tiny ones is to avoid hyperinflation and overdistension. I would start earlier with more gentle treatment options, non-invasive, if they can tolerate it. If not, you may want to think about the jet. The oscillator can probably work in some cases, but if you start to gastroc, switch to the jet. And then I think PEEP is the safest, most static, stable pressure we give. And if you're PEEP-ophobic, don't even look at it. Just look at the mean area pressure. Sometimes people are more afraid of PEEP than they are mean area pressure. So if you're afraid of PEEP, just look at the mean on the jet and dial it in to where the baby's oxygenating and ventilating quite well. And I'm going to end with one last thing. I found this slide when I was putting this paper together. I haven't talked about this for a long time, but I came up with this concept when I was falling in love with my wife. I was looking for an acronym for my laws of ventilatory efficiency. And there I had love, right? The laws of ventilatory, how are we going to be most efficient with our ventilator? I'm still in love, by the way. So there's the laws of ventilatory efficiency. And I have these two laws. And what I'm about to tell you actually made it into the opening comments in a textbook by Kropotkin and Goldsmith. So they call it and asked if they could use this love laws. And they didn't give you number 3. I'm giving you number 3. But they did number 1 and number 2. And this is really important. This is why you guys mean so much to me. I can't believe that I've got this amount of attention for this amount of time. I really appreciate it. But number 1 law of ventilator, if you're going to be most efficient with your ventilators, develop a specific strategy for specific pathophysiology. What that means is you can never take a cookie cutter approach to ventilation. You can't treat a BPD or maybe a meconium aspiration kid the way you do a PIE kid. They're all different. And even the same kid, if one kid comes in with PIE and the second one comes in, you can't use the exact same strategy. You got to be prepared. And part of that is number 2, which is you change the strategy as the pathophysiology changes. What that means is don't get on some settings and just stay there. We talked about that at lunch a little bit. Sometimes you might get on these settings, you're really comfortable on the jet, and you just stay there. Don't be afraid to change it as the pathophysiology changes. Then the third one, this is one I added on the airplane as I was flying into Winnipeg. And that's attach my special sticker to every ventilator. I'm in the process of making a sticker and I'm going to mail it to you. You just peel the back off. You put it on the ventilator, probably on the side. You don't want to cover up the setting. But this is my design that I designed on the plane. Safety first, be careful. This machine has no brain. Use your own, right? So all this stuff I told you, sometimes it may not work. So be ready to use your clinical intuition and your experience to make the right decisions to send the baby home with mom and dad. With that, stop. Sure. Any questions?
On this, the IP, long IT, and time. How long should we keep to, for how long? Like, I know for the recruitment maneuvers in the conventional ventilation, we have a period of time which is take 5 to 10 minutes.
Yeah.
But for this one, for how long should I keep this time?
What I would do is what Dr. Fraze did in her animal lab. We're finding that to be very effective. Watch the SATs. You don't need a blood gas. You don't need an x-ray. You just need an oximeter. When the SATs are stable, that's when you can take them away. And then if the SATs start to fall, you give it back. So it may be 10 minutes, it may be 30 minutes, it may be an hour. It's hard to say. Again, it all depends on the specific pathophysiology. Love law number 1.
And the other question is about the fee-based recruitment maneuver. The conventional used to be a fee-based, which goes up to high numbers, 35 or something like this. Is there any fee-based recruitment?
Yes, well, I'm so glad you brought that. Is a very important question. I forgot to touch on that. One of the things.
And then PTA is in
Small one, 5.
Can we start at 5 and then do the regular relay?
One of the things that Allison taught us is, that whole idea of giving side breath, taking away the side breaths, if the baby desaturate, give them back, raise your peak. So we're using side breaths to recruit. We started thinking about it. We thought, you don't want Cybreath if the baby has PIE. A better way to recruit those kids is more like an oscillator does, where you just use PEEP. It takes a little longer, but what you do is you turn your PEEP up by 1 to 2 if the baby has pulmonary air leaks. And instead of waiting 5 minutes, wait 15 minutes. If in 15 minutes you don't start to see an improvement in saturations, go up by 1 or 2. You're using no Cybreaths because Cybreaths are very detrimental to PIE. And that's a way to do it without Cybreaths. And someone asked me, well, why don't we do that on everything? Why do we just do it on PIE? And I said, because if you're using just PEEP to stabilize, you're also going to have to use it to recruit. So you're probably going to have to use a higher PEEP. But if you use the Cybreaths on a kid that doesn't have air leaks, you can probably, by the time you find optimal PEEP, you're not going to be on as much mean air pressure as if you just use PEEP. That makes sense. But yeah, in fact, I have a PEEP flow chart. That's one of the things I'll send you, Amy, is I've got a PEEP flow chart that shows you 2 different ways to recruit a kid based on your question. I think it's a very important question.
So if I was thinking about like lung recruitment, do we go up with the PEEP only or with PEP and PEEP?
Say that again.
If we are looking for doing recruitment, do we go only with the PEEP or PEEP and PEP?
Oh, yeah. Oh, I get it. Okay, I see. That's something Dr. Klein does, actually. He said, that's a very important question, too. There's so many important questions. One of the problems is if you raise the PEEP and not the PIP, you're cutting into your delta PEEP. So what Dr. Klein will do is when he raises the PEEP, he also raises PIP an equal amount to maintain his delta PEEP. And that's probably a good idea. However, if raising the PEEP stabilizes the lung, you may not need that extra PIP. But I think it's still a good idea to probably do it. And then if you start to see CO2 drop, then lower the PIP back down. But yeah, he's very adamant about, in fact, I've got a slide on it somewhere where I show him raising the PEEP and raising the PIP in an equal amount to maintain the delta PEEP, the tidal volume. I think it's a really good idea.
Going back to the Cybreath and the longer eye time and lower PLP, I think it makes a lot of physiological sense. But I wonder what will be the relationship between the eye time and the number of Cybreath that we use. Because to me, it would make more physiological sense to use a shorter eye time, not 2 seconds, not even 1.5 seconds, maybe 0.7, 0.8.
Yeah.
But more frequent. You know, instead
Yeah.
of having 2 or 3 breaths a minute with a 2 or 3 second eye time and low PIP, maybe use 5 or 6 using a 0.7, 0.8. I wonder. I don't know if somebody has done a study in the lab to see which one is more efficient, but physiological to me makes it would be safer, I think.
Yeah.
To use slightly lower eye time, still longer than what we use. So 0.4, 0.7, 0.8.
Yeah.
But more frequent, or double the number of Cybreath.
That's exactly what 3 of my colleagues, my former colleagues, are professing. They don't like me saying 1.5, to 3 second eye times. They said we're saying around 0.7 to 1 second, and then giving 4 or 5 breaths instead of 2 or 3. I don't think you have to go above 5 breaths, but it's not a bad idea. What I would do is experiment with a little bit. We're trying to get some data on it. When I did that study with Rob DeBlasi, it was really to test a new form of ventilation. I'm not supposed to talk about this, but I'm retired now, so I can. Somebody had the idea, like the problem with the jet, Marty Kessler said, is Bert made a really excellent volume ventilator and found a sophisticated way to turn it into a pressure ventilator. And because he said, but the problem is the servo pressure is always fluctuating. We like that because it adjusts. But we thought if you could stabilize that servo pressure at a value the kid likes, why do you want it to change just because he coughs or hiccups or something like that? So we thought, what if we, instead of setting a PIP, we set a servo pressure? So the idea was, what if we run the jet in its normal mode for a while until you get a good blood gas, and then you were able to lock the servo pressure. You don't care where the PIP goes, you just make sure you maintain the volume. And so we looked at some data on a few kids where they were on, let's say, a servo pressure of 4.1, and they had a perfect blood gas. And then some hours later, we looked at another point, and they were on a servo pressure of 5.3, and they had a crappy blood gas. Then they might have a servo of 4.6 and they had a crappy blood gas. Then they got back to that original servo pressure and their blood gas improved again. We said, boy, there may be something to stabilizing that servo rather than letting it run around to chase the pit. So we did a study on rabbits because I hope to build this into the jet someday. What we did is we ran the jet in Rob DeBlas's lab on rabbits until we got a good blood gas. And then we changed the software in the jet so we could lock the servo pressure. And that's exactly what happened. The servo pressure locked and then the pressure would move around, but the servo wouldn't budge. And we got much better blood gases consistently than running in the traditional way. We compared the traditional way with the locking servo.
Yeah, it's like the volume guarantee on the high frequency.
Yeah. It's like the Draeger's line guarantee mode. So we hope to do that. Why did I go down that path? What was your?
I was talking about the side breath, the high time, and the number of side breath per minute.
Oh, yeah.
But,
Yeah. You said something that got me going down that path. But anyway, I think servo pressure is a pretty good thing to watch. And if you get a good blood gas on a kid, you may want to make a note of where the servo is. And then
that's number one thing I always say to the fellow, just follow servo pressure. There's no point in doing a blood gas when servo pressure has dropped to half of what it was before, because you're gonna have a crappy gas. It's not the way around. So don't waste your time doing a gas. Just try to fix and go back to the initial servo pressure very
good, yeah. Yeah, why did the servo pressure change?
either a tube position or whatever, a situation, but you can't just do a gas. You know, it's the servo pressure is half where it was. You're gonna have a CO2 that's double.
Yeah.
Not the way around. So.
Yeah, servo pressure is a good tool. It's
I understand when servo pressure is decreasing, we are having a bad ground. After a while, like which condition the servo is increasing and we are
Well, your
getting
compliance is better. If your lungs are better, your CO2 is not go up unless your tube is out.
but your servo is going up and we are getting bad ground.
No. Unless the tube is out. If your servo pressure is going up, your CO2 is not go down.
Yeah, okay.
generally servo pressure is going up, it's good news. If servo pressure is going down, it's bad news.
Yeah, we always do what's like what the ruling is saying. That part is clear then, but I don't understand when the servo is going up, why we are getting that blood
Well,
pressure.
I mean, bad gases because CO2 may be too low. Your pH will be 7.6.
Oh, there is that way.
Yeah.
Yeah, CO2 is going the wrong direction. Yeah, too low.
The other thing is that my question is, when you do like a side breath, usually here, what is your overall time?
Well, I think, I don't know, the RTs, you know RTs here? No? I think the default is usually 0.4, so I don't think it's right.
So then we should be longer than,
Yeah, I think it should be longer and but low pH.
Low PID. I'm glad you said that, Ruben, because
The fact, we used to say, PFP sometimes when we started in the 90s, you can override a jet, so you can go the PFP higher. Than, so that was the worst mistake you can do.
yeah,
But then we said, well, let's stay below the PFP on the jet. But you have to much lower than that if you want to use a lower jet.
that was I think Michael was pointing out before. We should make the volume limited instead of like a kind of.
No, but I think using a fixed amount above peak, like 5, 6, or 7, that would be ideal instead of just using an arbitrary number. Because it depends on what your peak is. If your peak is only 8, you don't need more than 13, 14. If your peak is already 13, 14, you have to do 21, 22. So always use at least 6 to 8 above the peak. So I think.
So we don't use the ACDC.
Oh, no, that is the side that comes from the conventional. But I think, as I was kind of going to ask the RTs, the PIP they use here is usually much higher than that. When they use they use short TI 0.4 and PIP that are close to the PIP on the jet, which I think is too much. Yeah.
I can tell you a little bit about that. Bert and I had ways of managing the jet that we thought were right. And we'd go around the country teaching everybody. And when I first started training this hospital, I know I taught people wrong. And some of that stuff might still be lingering. And one of them was exactly what Ruben was saying. For years, Bert and I would say, always set the conventional PIP 1 to 2 centimeters below your jet PIP. And finally, the physicians started asking us, why do you tell people that? And we said, because it makes sense. They're both PIP. They said, it makes no sense. They have different objectives. The objective of the conventional PIP is to reach the critical opening pressure of a collapsed alveolus. The purpose of the jet is to blow off CO2. It's not going to open the alveolus. Why would, let's say they said, this is what they would tell us. Let's say it takes a PIP of 32 on the jet to get the CO2 you want. But to get a modest chest rise, which is all you're looking for with the side breath, it only takes 24. Why would you want to take it to 30 just so it can be close to the jet? We thought, man, that makes sense. You know, I don't know why we were telling people that. So what we learned from that is it doesn't matter where your pips are. If your pips are close or far apart, then it's okay as long as they're meeting their objective, which is opening the lung for the conventional and getting the CO2 you want for the jet. And what we found is, like Ruben said, is hardly ever will your conventional pip need to be up to where the jet pip is. And don't be afraid of the jet pip because we know that it attenuates very quickly. It's not the same down here as it is out here. So you can go higher on the jet pip. Yeah, you shouldn't be, if you reach or exceed the jet pip on the conventional, like Ruben said, the jet will pause for the duration of the conventional breath. The jet's always looking for the high pressure, and if it sees something higher, it'll pause. So if your conventional pip's too high, you'll hear this. Pop, 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 pop. Pop, 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 pop. It'll start again as soon as the breath goes away. But it's doing what it perceives as protecting the patient from what it perceives accurately as too high of a pip.
It's interesting that we still don't know what to do with side breath, because in the original high five study, no side breaths were allowed initially during, and the results were not good. Then they introduced side breaths, but they didn't know how to do it.
Yeah.
But we're still talking about side breath.
It is. We at Benel, we've stopped calling them, well, not we, I don't work there anymore. But at Benel, they've stopped calling them side breaths and they're calling them recruitment breaths. Because they said, you know, if you're reading a great novel and all of a sudden you do one of these, that's a side breath. You might need one if you're really immersed in the novel more often. But that's not what we're trying. We're not trying to side a patient. We're trying to recruit him. So we're getting away from that term side breaths and we're using recruitment. We're also getting away from looking so much at the PEEP and more at the mean airway pressure. So we're learning, you know, and I can tell you, in all honesty, I'm not trying to pat you on the back or anything, or be overly thankful, but I am thankful that most of what we learned about the jet has come from people like you guys. When Bert and I were teaching people, we didn't know, you know, we taught what we knew, but it was through clinical experience and the people actually in the trenches that taught us. So, and like Molly said, we're still learning, you know, we got a lot to learn about the recruitment breaths, but I think we're getting it dialed in now with these longer eye times. And I think what Ruben said is really important. I've been always advocating 1.5 to 3, but some of my former colleagues are saying, no, you don't need that much. But like Ruben said, you might need a few more breaths. In the anesthesiology department, you know, they'll do 20-second breaths with low pip. But we're not comfortable doing that on the jet.
I think we were spoiled here for many years by Roman, because he was such an enthusiastic individual who was passionate about the babies, and he knew what he was doing with the jet. And certainly at our site, we relied a lot on John.
Yeah.
And we've lost it. I mean, we're good RP, but we've lost that experience that he had.
Yeah, he came and did. I used to have him give a lot of talks for us at the Snowbird conference. And we would do these things at the big international high frequency conference at Snowbird, Utah. But John came in and twice he did presentations for us at our roundtable discussions in the evening. And I thought that guy really knows the jet. Yeah, he really does. He's still passionate too. He emails me all the time. Well, he texts me all the time. And he still has that drive. But
I'm glad you're not calling that side breath anymore, because the definition for a side breath on regular breathing is 1.5 time of the tire volume. So for a side breath, basically, if you use a tire volume of 4 or 5 per kilo, a side breath would be more than 10.
oh wow.
We would never want to do that. So And the reason that a baby can afford a side breath is because, as you said, it's negative pressure.
Yeah.
It's not positive pressure. But when you try to mimic that side breath, doing a positive pressure, you can create a lot of damage. It's not the same thing.
Good point.
That's why you will never use a side breath on a ventilator, because that's never physiological. So I'm glad you can call it different.
Recruitment bus, yeah. And,
It's not close to a side breath.
I just found out recently that there's another thing my former colleagues are advocating. I talked about it this morning, but for those of you who didn't hear it, what some hospitals are doing, and this was the brainchild of one of I call him my idea man. He's one of my former colleagues that's always thinking about this stuff, and he's really good at it. And he came up with the rule of 5. He said sometimes over a 12-hour shift, a kid might collapse a little bit, or he might have a whole bunch of new alveoli because he's growing 3.3 per second. And some of them are atelectatic. So I said what he's advocating to some hospitals that are struggling with the baby that they can't stabilize, if it's periodic, like every few hours or so, he'll crump or something. What they do is in the very beginning of each shift, they'll do the rule of 5. The rule of 5 is 5 side breaths with a PIP 5 centimeters above the PEEP with an I time of 0.5 for 5 minutes. So again, a rate of 5 centimeters above the PEEP, the 0.05 I time for 5 minutes, 5 breaths. And then they'll go back to CPAP. And it's just a way of recruiting and stabilizing, and then they go back to homeostasis.
My question, they were doing this one as a kind of like a prophylactic,
Yes,
without seeing any servo changes, like.
Yeah.
Nothing absolutely.
they are, and that's where I have the problem. That's why I'm not pushing it yet. It's something to think about, because I think they're doing it because the kid doesn't have enough PEEP. That's why they have to do it. But sometimes they'll do it just because they're used, it's protocol now. We do it at the beginning of every shift, even if the kid doesn't need it. So yeah, I'm not totally sold on the idea, but I get what they're trying to do. It's, just trying to give the kid a few recruitment breaths at the very beginning of the shift, stabilize, and move on.
By the way, I'm using high frequency, not the jet, huh? And the new machines also in high frequency, they have a side opportunity. So like I'm using, is it like the same mechanism working with the jet? Yeah, that's a drag, right? No,
That's
the only. The Cincinnati?
Leone?
Leone, the one.
Oh, Leone, yeah.
Leone, I think must be similar to the drag.
It's from Switzerland. It's a very famous brand in Europe. And they have a site opportunity, not the IMV high frequency, but CPAP high frequency plus site.
Gotcha. Yeah.
Yeah,
There's
but
a few out there.
I think I'm on the Draeger, I may be wrong, but the Draeger thing has similar mechanism as the jet.
That's it.
Passive expiration.
Yeah. As far as I
Passive,
guess,
yeah.
the system medic is the
The
one
one is
active
the only
in and
machine.
out.
But these are very small machines that you can't really.
Which one?
The Leone and the Draeger.
I think the trigger needs up to 2.5 kilos or something.
It's
The
still,
only has
still
no
small.
limitation.
Still small.
The one is up to 30.
There is one installation, it's E5.
Yes, as a member, it's not that big. You look at the size of the members of the sensor medic.
Oh, yeah, but this is.
That's why you can't use it.
Do you guys use the servo boosters here?
We used to, but now we will increase the TI. It's very.
Good, yeah. I think that a lot of times we use the boosters because we didn't appreciate eye time.
Yeah.
The boosters, by the way, it was the brainchild of a respiratory therapist in where was he? Winston-Salem, North Carolina. His name was Matt Brink. And he had this kid, it was a pediatric patient. And they maxed the jet out at a PIP of 50. And the servo pressure was only 8. The servo pressure can go as high as 20. The servo pressure basically is a flow knob. Think of it as a self-adjusting flow. And they said, if I could just get more servo pressure, I could put more volume in, but I'm stuck at this PIP of 50. So he started thinking about how the pressure is measured. The pressure is measured through a pressure monitoring tube that comes from the life port adapter back to the patient box. And it's a certain length and a certain diameter to control attenuation so we can get accurate reading of the distal tip. And he thought, I'm going to add a little IV tubing extension set in there I'm gonna make the waveform travel further. So he added it and the pip dropped and the servo went pushed up to send it back to 50. He saw a little bit of improvement. So he put another one in. And then another, and pretty soon he had over a meter of these IV extension tubing sets. And the kid turned around because he was able to get the servo pressure up to 12. And there was a hospital in Vancouver, BC. They had bless you. They had a 15-year-old kid who was face down for surgery. It was spinal surgery. They're trying to straighten his spine. His back was flailed open. And the anesthesiologist lost the cuff on the tube. And Dwayne Wong said, I've got a ventilator that doesn't care if there's a leak around the tube. It shoots the gas down into the airways. Well, go get it, go get it. This was a big kid. This kid's 14 years old, but they couldn't ventilate him. So they started putting those boosters in. And that drove the servo pressure up and they got him through the surgery.
Now, the only reason the jet has a limit of 50 for FDA, right?
Yeah.
Yeah, so that's, you're basically pulling the machine.
Yeah, the way the FDA works is they look at the data that you provide in order to ask for approval. And then they set the limits based on the data you provided. We had no kids that went above 50. So they set it there.
I have a question to Robin. So I had witnessed many cases we had to use this booster. So and that it worked very well, like because they were very like a stiff lung and we were not able to open. So should I, in this condition, should we increase the inspiratory time rather than like what is your like a target?
Like I said, when you get to about 40, 22, 40, low 40, you should start thinking about increasing the jet.
Yeah, the eye time, as Ruben said, is doing the exact same thing the booster is trying to do. Give more volume.
Like we have a limit for the time?
Well, I think the limit is 0.034.
Highest you can go is 0.034.
Most of the time, you don't need to go that high.
Yeah,
I usually go from 0.02 to 0.024.
Good.
0.028 and then 0.
I'm smiling under my mask. I love it. Yeah, that's people sometimes take the eye time too quickly, and then they can drive the CO2 down too quickly. So we recommend 0.024, 0.20.
Yeah, but if you go from 0.02 to 0.024, it's 20% increase. That's a lot.
Yeah, and you're delivering that for 260 times a minute. Minute ventilation will improve dramatically. By the way, I do want to say that in a tribute, one more tribute to Molly was I bought this in Edinburgh, so I wore it for you today.
Did it cost you?
It did, yeah. Walker Slater. Yeah, I got pants to match, but it was just too warm for that.
Support the British economy, they need it.
Yeah. It's a tough world all around. But thank you so much for all you do. I think you're doing honorable work, trying to send babies home with mom and dad. And, watching my own kids be born was one of the greatest joys of my life. And now playing with my grandkids. And I just love when people send babies home with their mom and dad. So thanks for everything.
Thank you.
Thank you.
Yeah. Thanks.
My pleasure. And I think my colleague Brian King is coming in a few weeks. And if you give him a whiteboard and a pen, you'll be amazed. Yeah, he's really good. Okay, thanks.